That's all right. So where you see referral processes for Southwest Behavioral Health Services, for Encompass Health Services, for Child and Family Support Services, a lot of the processes are fairly identical, almost identical, very similar. But we wanted to just kind of jump in and go through what it looks like. So we're going to talk a little bit about what our referral process looks like, and then different types of eligibility, because there are more types of eligibility practically every 3 months than any of us can keep track of. Angela is like the guru for that stuff, so I'm thrilled that she's here, because if it was just me, I think I'd get lost. I'd get myself in a circle. But we'll kind of just jump into that process as well, and then we'll talk about what types of services are offered at the different agencies and how to connect for those.
Okay, so a lot of you guys are probably familiar for your referrals that you've done with the Guidance Center. The name Maureen Mace is probably very familiar to you all. Unfortunately, she was not able to join us today. She is our member services lead at the Guidance Center. So her and I have both been there over 15 years with the Guidance Center. So we've also seen a lot of changes over the years. And so we sometimes are just kind of rolling with the changes and trying to accommodate everybody the best we can. So initially, for a lot of you, whether it's from probation or if it's from the public defender's office, we're receiving referrals either via email to our scheduling email directly to Maureen Mace. Sometimes it's going to Dr. Babbitt, our chief clinical officer. They're kind of coming from every which direction. So oftentimes we prefer for it to just go to our scheduling email. Sometimes for probation, you guys are handing them over a slip that says, go over, see the Guidance Center, hand this over to them. And it usually says mental health assessment or substance abuse assessment on that form. So when we receive those, we first look up the member in our system, and we want to confirm, one, if they're in our system, we're going to confirm eligibility for services with the particular service they're wanting. If they're wanting a substance abuse assessment, that's usually pretty quick and easy for us to verify. If you're wanting a psychiatric evaluation, things like that, because those are a little bit more costly, we're going to want to verify that they have access funding. Schedule an intake assessment and or first service. So if we get those via email, if the member is in jail, we will send out the 4-page registration packet to have them fill that out. The biggest reason we need that documentation signed is we need that member consent. Oftentimes for the substance abuse consents, we need that to be able to go and have our staff assess the member. We can assess for mental health all day long with general consent, but that substance abuse consent form is, we can't have something about it. For schedule and intake assessment, we can go to the jail. Those do have to be in person. So those might take a little bit more time than being able to just hop on the phone and assess them over the phone. Do you want to elaborate on that part of it?
Yeah, I mean, we do have dedicated staff that are able to go into the jail 7 days a week. We have people that are available even on weekends. The county health department helped coordinate with us to be able to offer that and make sure that access is available. And part of what the reasoning is for that is I think all of us probably know that when someone finally says it's okay, I'm willing, I want to go for treatment, I'm ready for treatment, or I'm thinking about treatment, those are the times when we've got to strike while the iron's hot. And so we want to definitely be getting in there as quickly as we can. Typically, we're over there within a couple of hours. It just kind of depends on what the schedule looks like for the jail, as well as on our side if there's a lot of crisis going on. But we do try and get over there every single day. And so just before I forget, we will be sending out after the training a copy of all the slides on PDF, as well as a copy of our 4-page brief intake. For those of you who have gone through the nightmare of TJC's intake packets in the past, they used to be pages and pages and pages and pages more than that. The full packet technically still is from what the state requires from us, but we just needed to pare that down to a 4-page document that just has a few things on every page to fill out, and then like Angela was saying, just be able to consent for that. And so those are the most important pieces.
When they come back to us in person, they will have to finish the rest of that awful packet. It is a lot of work, but like you said, it's part of the state requirements. It's not just something that TGC has come up with. So unfortunately, we'd love it to be just a couple of pages, but unfortunately, that's not the reality. One important thing that we like to have when we get referrals is the release of information to coordinate. We do get a lot of calls on a daily basis from probation officers, lawyers' offices, wanting to find out the status of their person. Have they started services? Have they been attending services? So I know probation has that release of information. If you have your own release of information, we are able to use that. The biggest thing is making sure that you have something about a substance abuse consent, if that's what they're coming in. If, like for probation, sometimes when the members bring in those slips to us, they just hand it over to us and they say, I don't know, my probation officer told me to come here. And we will do our best to try to screen or get more information out of them. If at the time of the referral, if you can attach any other paperwork or email that paperwork to us, it will help our intake or our assessing clinician make the best possible decision-making on as far as services that are needed. When there is maybe a probationer just got in trouble for getting a dirty UA, they're being sent over. If they're not giving us that information, and when they go to be assessed and they're not forthcoming about that, we're not going to be able to recommend treatment. So the more information that you guys can provide us, the better. Once the member attends their intake appointment, they will then complete the assessment and the treatment plan. They will make treatment recommendations, and then a care manager will also meet with them shortly after to talk about available services to them. Once that is complete, then the care manager and or Maureen Mace, who handles most of our referrals from the county and from the legal defender's offices, she will let them know if they have attended their appointment and treatment recommendations were made. If you need additional information, we're happy to give that to you, and we can coordinate with Misty Pretty in our medical records department if you need those records. Again, biggest thing is any kind of collateral information. Sometimes our members that are currently in the jail, they're not from Flagstaff. They're not from Coconino County, and they have been receiving services elsewhere. So that's always an important question to be asked to those members is, are you receiving services anywhere, or have you in the last year? Because that can cause an issue. If they do have access, their access is possibly suspended because they're incarcerated. And we have to do what we can to try to collect information from that health plan or from their original home health agency.
Part of the reason some of that, what happened in the past year information is so critical for us as well, is it can open up other funding sources if the person doesn't have access. We don't just take folks that are on Arizona Medicaid or access. We have block grant programs, and we'll talk about a couple or one of those here in just a second. But we have block grant funding. We have special fundings for kids getting services in schools. We have opioid funding. We have just different pockets of things, and it's up to our front desk staff sometimes to get super creative if the person's not eligible for access, makes just a little bit too much money because you know, they went back to work post-pandemic and success, yay, we like that. But at the same time, if it disconnects them from eligibility from access, we want them still to hopefully be able to get services. So we do what we can to get all that information up front, and therefore say we've got a funding source for you to get services rather than you having to pay or do sliding scale or anything like that, because we do that at last resort.
And having the collateral information too is very beneficial, especially for the lawyers that are requesting maybe SMI determination. The more information we have that we can provide to Solari, the easier it's going to be to approve those members to be designated as seriously mentally ill. So more information is better. I know that can be a little bit of work when it comes to obtaining that information, but it's going to benefit the member at the end of the day. And go to the next one. So Trevor talked a little bit about the different payment options for services at the guidance center. So obviously Medicaid is always, you know, that's one of our main payers that's coming through to the guidance center, but we do have a lot of commercial and private insurance health plans that are coming through the door. I know that Southwest takes commercial insurance, so does CFFS. If they need assistance with applying for access, that is something that we can do at the guidance center. Obviously, we do have the local DES office that's right across the way. If somebody is currently in our psych hospital, we're able to apply them while they're on the unit. And so the turnaround time for while they're on the psych unit is pretty quick. It's 3-day turnaround. But now since they lifted pandemic benefits through access, it could take up to 45 days. But our goal is to try to get them in. So if you're referring somebody for substance abuse services, there is special funding like our federal block grant that would then offer them services, maybe while that access application is pending. Or, you know, they're IV drug users, women with children, or pregnant and parenting. So there's different state monies available, as he has here, opioid programs, crisis services for everyone. So we're never going to turn anyone away for a crisis service. So that's 24/7, 7 days a week. We do have a sliding scale. So based on their income, so if they apply for access and they are denied, we have a slide fee scale that would show them if they're available for a discount. So it goes anywhere from 100% to 20%. Obviously, if they had 100% discount, they're going to qualify for access. I am not allowed to approve any of those fund sources unless they have applied for access. But if they're incarcerated, there's wiggle room with that. Not all access and commercial private health plans cover all available services. So there are some services that we are not able to provide to different health plans. We are contracted with all the ones that are here in Northern Arizona. We are contracted with some like Mercy Care and Easy Complete Health, which is further south. But that doesn't mean that they're going to approve us to provide START services. So that for our 30-day program for substance abuse, we do have to get prior authorizations for that. But it might just be if you're providing us with that collateral information that the person's currently in Coconino County Jail or now moving up to Flagstaff, we might be able to get some of those authorizations to go through. However, if they've been living in Flagstaff, like we have a lot of people that are traveling north right now for the summer, I need to do an address change with access. Once we do that address change, it should flip them to a plan that's available up north. So it should make it a little bit easier for them to access services.
And for folks coming out of jail, we can help get their access reactivated after it's been suspended. And then we can also expedite referrals if the person's needing certain types of levels of care. But where the prior authorization kind of knocks us back a little bit is that causes a 3 to 14 day delay for us in being able to get services. So we know the person's coming out of jail. They have struggled significantly with being clean and sober on their own. If they could do it on their own, they would have already done it. So we're trying to figure out how we can best connect them in quickly or offer services in the interim while we're waiting for the prior authorization to go through. The nice thing is being in a psychiatric hospital or being incarcerated are kind of sort of magic words that get the state to really move things a little bit further, a little bit faster. And we've definitely seen from health plans getting expedited prior authorization requests, sometimes by a miracle, even same day, but we can't ever count on that. Usually it's 3 to 14 days. The health plans all have up to 14 days to do that. And the folks that are on things like block grant funding and all of that, it's even more difficult. There are a lot more requirements that we have to meet as far as our documentation. We just have to be able to demonstrate that there's medical necessity for a service. And oftentimes what we'll see is if we get a referral for residential, they'll say, well, the person has been using and they are experiencing homelessness. That alone to most health plans will not be enough to meet criteria to be in a residential treatment center. And so we have to do more of a kind of in-depth assessment to get in there and find out exactly what's going on with their use history, their treatment, what's worked in the past, what's maybe not worked so well in the past, so that we can fill out all those fun red tape documents to be able to get them connected to the services that we know they would benefit greatly from. We want them to be able to get them.
Yeah, my best suggestion, again, I know there's a lot of different people that everybody knows at the guidance center who to reach out to. We really want to use that scheduling email or Maureen Mace, because then we can go through doing the jail intake, because that's where we're going to collect that comprehensive information. And then also, if she, needs any other collateral information from you all, she will reach out to you. Our residential program, they're really busy, the case manager up there, and, yes, we always want to get the members in, but on the back end side of things, we got to make sure we've got all of our paperwork together so that that insurance company is going to authorize that stay.
All right.
Yeah.
Sorry. Okay.
Take that.
So one of the different possible services that we can offer is for folks, whether in the community, in jail, or what have you, if the person appears to be experiencing some sort of really severe symptomology where their functional level is struggling, they're maybe not managing their work, their schooling, etc. They're just struggling in relationships, struggling with housing, just struggle. There's a good chance that they may meet the state's criteria for serious mental illness. And in Arizona, the way that this is set up is that they need to get a psychiatric evaluation and get diagnosed with a qualifying diagnosis. And then we complete an assessment to say which functional criteria are met to be able to determine them as having a serious mental illness. So we are able to complete those assessments. We have done them in jail before. We have done them in a variety of settings. We can do them over Zoom. We can do them in a number of different ways. So they are available. And what happens from there is after we've completed a detailed assessment, it usually does take at least 2 hours because the packet for Solari is extensive. Then they have psychologists on staff that review the request for an SMI determination and determine yes or no. Do they meet the criteria currently for having a serious mental illness? It's kind of a yes, no, there is a maybe category of, hey, if we get more information over the next 90 days, then you could always send it back to us, etc. But those are a lot more rare these days. We're usually getting clear yeses or no's. And so what happens and why this is beneficial is having an SMI designation anywhere in the state of Arizona qualifies you to continue your behavioral health services, regardless of whether you were on access or not on access, never on access. You lose your access for whatever reason, you still get to continue. You get that continuity of care because there are state dollars that that are dedicated to serving this population and making sure that they're able to continue services. So they all get enrolled with a regional behavioral health authority as of October 2021-ish. That's 22. Was it 2? Care First is the regional behavioral health authority that manages all of our members with serious mental illness, and so they're able to help connect people with benefits and provider agencies, etc. I think one of the things that's out there is in the past, there's been a lot of experiences, not just from us in the health room, but from justice partners, from other community agency partners like Catholic Charities referring folks to us, where they've got both symptoms of a serious mental illness, but also substance use that's complicating all of their symptomology. And it all just sort of wraps together. And it used to be that they would try and do sort of a chicken or the egg analysis to figure out which came first, because if it was substance use that came first, then they're not going to get the SMI designation. They really moved away from that either or situation, and they're really basing it on, do they actually meet diagnostic criteria for a mood disorder or a thought disorder or psychosis? Do they meet criteria for a personality disorder? If any of those are found to be appropriate diagnoses, and they have those functional criteria, even if they're using substances, they can still get SMA designation. That's something I think in the last, my observation is about 18 months or so, they've really stepped up to make sure that they're not letting people slip through the cracks and just saying substance use, no go for SMI. And so that's a nice positive change that benefits people that are actually trying to get help. Is there anything that you want to throw in?
I think just reiterating with that, especially if they're currently incarcerated, any kind of collateral information, if they came from another state, a lot of the members that I've come across, even just in our psych hospital, they know the different psych hospitals they've been to, the other agencies that they were receiving services from. So the more information we can collect, the better, because then they can really lock that in and get those SMI determinations approved. If we're going into the jail, have no information whatsoever, and we have our person going in to assess, it's really hard for them to approve those SMI determinations without a solid diagnosis from past history.
One last comment I'll make on these is that SMI determinations can be requested from anyone 16 and a half years or older in age. I didn't pick that number, but it's there. At 16 and a half, we can start to do an SMI determination with a person and talking to their family, getting collateral information, all of those things. The designation doesn't technically kick in until their 18th birthday, but we can start the assessment process earlier. In fact, we prefer to do it that way, just because we know what we're looking for as far as functional criteria. Or having trouble with managing their independent living skills and all of that stuff. And figuring out, is this something that we can counsel someone through? Is this something that our case managers or our family support partners can go and help this person with? Or is this something that is chronically going to be an issue for this individual, meaning they would meet the criteria for SMI and benefit from that level of services? Additionally, in Arizona, SMI status offers you some opportunities for additional housing resources. Housing and Urban Development has given out millions and millions and millions of dollars over the years to different states, specifically geared toward people with serious mental illness. And we love that. We really appreciate that they push those dollars out so that we can get people connected into housing, because permanent supported housing, as a lot of us already know, makes a massive difference in someone being able to engage in recovery, be able to get well, and all of that. And so having the SMI designation does entitle you to apply for housing. I think you probably would also all know that wait lists for housing everywhere are ridiculous. It is extremely difficult. And it takes a lottery ticket, an act of Congress, and just flipping a coin on the right day to get someone connected to housing resources. It's really challenging, but it doesn't mean we don't try. And then also there are residential programs for adults with serious mental illness. And so we have one, but there are plenty of other ones around the state. There is a little bit of scrutiny going on from Access currently. As if you haven't heard, Access is in the throes of the largest fraud investigation they have ever done. And I think we're all thankful for that, because we don't want providers out there billing for things that are not legitimate services and taking the dollars away from the people who really desperately need ongoing care. So the requirements for getting into a residential facility for adults with serious mental illness are going up almost weekly for us. We just had one health plan send us a new authorization form. It used to be 2 pages, it's now 8. It's a good time. So it's just lots more checking, double checking, triple checking that the person really needs to get that level of care so that we can refer them to it. But for those residential units, they definitely need that. And you can have a serious mental illness and go into a substance use focused residential program as well. They're all technically co-occurring, meaning they treat both mental illness and substance use issues, but they have significant focus in one area or the other usually.
We talked a little bit about the substance abuse block grant. We call it SABG funds. If you've been with the county for a long time, you guys probably also know it as SEPT funding, same thing. We do have our priority populations with our SABG funding, pregnant women with dependent children, intravenous users, and opioid users. So, you know, the minute we screen somebody that's coming in needing a substance abuse assessment, if you ever look at our registration form, page 2 has a substance abuse history, and that's the information we're looking at. That's the first thing we go to look at. We see it there. We know that we've got to really push these folks through and get them seen as soon as possible. There are some service limitations like medications and long-term residential. So if they are getting medication-assisted treatment like methadone, Suboxone, that's going to be covered by these SABG funds. If they're maybe getting a medication for, say, depression, unfortunately, this funding is not going to cover that. So that's why there's always that big push for us to try to get them on access. If they have a commercial insurance, we're always going to bill that commercial insurance first. They are the primary payer. Any of our grant funds are the payer of last resort. So they would have to report that information to us. So they might have an out-of-pocket cost for that depression medication, but for their medication, it's going to be 100% covered. They do have priority access to services for those without alternative funding available. So, you know, usually when my staff ask those questions during the referral process, if somebody's calling on the phone or emailing us, they're going to see what funds were available to them. If they're in need of crisis at the moment, because maybe they're detoxing, we're not even going to worry about the intake process. We're going to send them straight over to crisis, and then we can possibly get all the rest of that stuff done while they're in our CSU.
Which is a nice segue. All right, so well done. It's almost like we prepared. Crisis services, any single person in the state of Arizona, because of state allocations of funds, is eligible for crisis services. It doesn't mean it's unlimited crisis services and a lot of the different things that we would love to see and getting ongoing care, but you can get a mobile crisis assessment. You can get an on-site assessment. You can get up to 72 hours of stabilization services. That's not inpatient, that's still an outpatient level of care. It's in a kind of low stimulation outpatient area with chairs and nursing assistants and all of that fun stuff. And when Angela was talking about, we will just get them into stabilization first. That's where we would get them in there stabilized. If they need a detox, we're working through that process. And then as they're completing their detox, we're working on, all right, what do we need to do to try and get insurance for ongoing services, ability to pay, et cetera. Our stabilization has nursing. We talk about the stress in there and detox. It also just kind of gives somebody a respite from life. It is stressful being an adult sometimes. And there are some folks that just benefit from being in a quiet space. Knowing that there are staff members present who will support them and help them with whatever their issues are. And so we love having those folks come in to get that respite for up to 24 hours, usually. But they can kind of cycle back through and get up to 72 hours overall of stabilization. And this is available 24/7, 365, as long as there's an open chair. So, and they're almost always is.
Yeah, well, I was gonna ask her, what's the capacity?
So the capacity on our crisis stabilization unit is 7 chairs. We're full, I would say 48 hours per year. And so we average about 4 chairs filled all the time. Sometimes there's 2, sometimes there's 6, but very rarely do we go all the way to 7, because usually what's happening when we get to 6 is we're trying to figure out if any of these people need to be inpatient. We need to reassess them. Do we need to get somebody a safety plan? Is anybody getting close to ready for discharge? Because people are coming in all day, throughout the day, all night, throughout the night. Maybe somebody's getting closer. And so we try and move people through the system as much as possible to keep ourselves from hitting a full status, because we just don't want to be turning people away.
And how do people find out about this? I mean, I assume some people are just referred there, but and you probably have repeat people coming in.
We do.
So I think even the other agencies, Southwest, CFFS, Teros, everybody that's out in the community, probation officers, they're bringing folks in for crisis. When our crisis workers assess them, if they feel like they need a higher level of care, they're not ready to go home, they're going to recommend CSU, and then obviously it's a voluntary unit, so it is up to the member if they agree or not. But yeah, we see people bring them in on the hour.
Yeah.
For crisis services.
Teros and Police, that CARES program brings in
Oh,
folks
yes.
at the time, we have a lot of drop offs through that. And then there's word of mouth too, I mean, people in the homeless shelters are very well aware of stabilization services. Sometimes the homeless shelter staff are bringing people over to us, and so it really just kind of doesn't matter how they get there, we just figure out a way to get them in and go from there. Yeah, please.
Is there a way, if someone needs to detox, is there a criteria that needs to be met if someone is too drunk for your unit? Like when our officers are out in the field, is there a BAC we're looking for, or like a health level of health that we should look for to decide the guidance center or the hospital?
Yeah, that's a great, very difficult to answer question, so thank you for that. It is, it's not blood alcohol level related, but it is, if there are any symptoms of heart palpitations, if there's any breathing issues, if they have any seizure history during alcohol withdrawal, most of the time we'll assess them, but we're probably going to be sending them on to the emergency department and coordinating with FMC to get them back once they're medically. And so that's the work that we're putting into that. It's not always easy to tell, but what we do is when they come in for crisis, we take their blood pressure, we'll have the nurse assess them. And if there's anything that's concerning, they'll staff one of our medical practitioners on call, and they'll make the call of emergency department or good to stay and just monitor. So I would just say default to bringing them to us unless they're just completely immobile or they're non-responsive. Like if they're not able to answer basic questions, we're probably going to refer them out because we just don't know what their history and need them to get emergency services first. So it's kind of that. We'll try and remember to include, we do have criteria that we get to the hospital when we're sending them. So I'll put that in the back end. So thank you for that.
It happened to us also.
Oh, okay, fair enough. And there are times though, when someone will say, oh, just take them to the hospital, and we try to train our crisis workers not to say that. But then there are times when they just hear some key phrase or something like that that reminds them of somebody that was in the week before that they had to send out, or they coded on the floor or something like that, and they kind of get scared off for a little while. So always good training opportunities for us. And just kind of call it.
One of the other topics that usually comes up when we talk about our referral process is transportation. Transportation is available for our behavioral health services and appointments. If the person has no other resources, they don't know how to utilize the bus system here in town, there is transportation available to them. It's limited. I do have one driver currently. We do have some people already like on a regular schedule. If we can accommodate that, we do reach out to the health plans who require anywhere from 48 to 72 hours advance notice. If the member has access or one of our substance SADG funding, SMI non-T19, they're able to call the health plan and arrange their own transportation to and from their appointments at the guidance center. If they're receiving medical services out in the community, like say North Country, and they have a primary care appointment, they can look on the back of their card and arrange that transportation as well. There's only Apex and Swoop in town that assist us with our transportation. And those can be a little frustrating at times because one, they don't pick up their phone, or maybe they're doing other transports out in the community. So we always want to try to encourage bus if they have access to a bus stop near them. We do offer bus passes for those of our members that maybe need the paratransit. We can assist with getting that paperwork filled out, so maybe they can get a direct pickup and drop off to the guidance center. For crisis services, transportation is never going to be an issue unless you're trying to go outside of staff. For crisis services, we are always going to make sure that the person gets back safely to their destination. If they're trying to go somewhere else that's not listed on there as an address, we're not going to just drop them off in Sedona. So we will take them to the shelter. There is with Mountain Land Go, they've also worked out a program to where if the person is staying at the shelter, we can arrange transportation from the shelter directly in front of the guidance center. They also have a drop off to Walmart to the guidance center or Walmart to the shelter. So they're just right there in that part of the east side of town. So they're really trying to look at access to care for our members.
So the health plans all do contract with specific transportation providers. Feel forgive the terrible pun, the bumps in the road we run into with this are that they will often take way too long to respond. Or what we've had lately with all of the health plans providers is they'll actually send drivers from Phoenix or from further away to come up to pick someone up to drive them 10 minutes across town to come to an appointment or to come in for services. And so it just causes all kinds of disruptions and things like that. We always encourage reaching out to the health plan when those types of things occur because it's their contract. And so we definitely want our members to get the transportation they need, but Care First and Health Choice and the other health plans all need to know what problems are occurring to you to deal with that.
Yeah, sometimes it's just the wait times in general that's frustrating for everybody to try to get through. But you know, sometimes they're like, they showed up 3 hours early for me. Angela, I'm like, I'm sorry. I'm like, you told them what time, right? Yeah, 11 o'clock. And they said, well, we want to make sure they weren't late. I'm like, maybe they're not familiar with flight staff for 20-30 minutes. But if they do schedule transportation, it is possible that they're going to arrive at least an hour prior to their appointment.
So this is another time when reaching out to our scheduling email or the front desks or crisis staff at any of the providers is a good idea if transportation issues are coming up. We can usually kind of strategize through things. We have our own driver that we can just kind of assign randomly at a moment's notice to just go do a transport. There are times when we have staff on our 24-hour units where we can spare somebody from a unit to take someone somewhere. So it's not a lost cause, but it is sometimes difficult and frustrating.
And if the member is giving us a call or you're giving us a call, letting us know that there's an issue, maybe we can move somebody up. Maybe they showed up early for their appointment and we can put them, you know, schedule them to be seen next and then send someone out to go pick them up. So just communicating with us, whether it's via email or phone, we'll do our best to accommodate you know, those appointments, because of course it's not the member's fault or something like that.
So I'm going to go through available services kind of quickly, and I'll throw in little tidbits about other providers as well. But TGC has been here since 1969, providing a lot of different services. We'll start with kind of the most intense and work our way to less intense. We provide psychiatric hospitalizations, both for voluntary and involuntary individuals at our psychiatric acute care or PAC unit. We have 24/7 nursing and staff on site to help with de-escalation, to help with therapeutic resources, to do groups throughout the day. We have peer supports, all of that. Our social worker is running amok all the time doing discharge planning to get resources for housing, for ongoing transportation, connections to services. If somebody wants an intake at Southwest or somewhere else after they've gone through our hospital, we'll set them up and get all of their appointments all squared away so that they were walking out from our hospital with a full list of all the things that they need to go follow up with. And we do have all of our folks see a medical practitioner every single day. We can go on. 24-hour crisis stabilization, that's our CSU, the place with the chairs, that's kind of low stem. We do provide assessments. The nurses provides assessments after crisis has done so. And then we try and figure out from a safety perspective, is this person ready to go back to the community, or do they need to kind of be here with us hanging out for a little bit, or should we even consider back? We'll do a lot of coordination with facilities and law enforcement. Our goal with law enforcement is to have officers dropping off back out the door to their car within 3 to 5 minutes. unless it's a really complicated case, we're usually able to do that. But there are times when it can take a little bit longer, especially if they're coming to jail or they're transferring over, if they're involuntary, that complicates things a little bit. We do have walk-in availability 24/7, and again, that's regardless of insurance, regardless of ability to pay. Crisis is funded and can be provided. Good. Residential, this is for both serious mental illness and substance use. We do trauma care, teach coping skills, offer family support and family visitation so that we can incorporate folks into helping the person when they're graduating deal better with their addiction and their ongoing recovery. We do skill building groups as well as individual sessions. And then it is not super fun to be on a residential unit all day, every day. So we do as many outings as we possibly can. The weather is cooperating with that for right now. So we're really loving getting the vans very, very busy and getting folks out in the community. For outpatient programs, we have care management, therapy, both group and individual, and that's for adults and children. We do couples therapy, family therapy. We use all kinds of different therapeutic models that are evidence-based and research-based. We have a primary care practitioner on site during our regular business hours so that folks can get medical care. What we have found is, especially for our adults with serious mental illness, they haven't seen a primary care provider in years and years and years and years and years and years. And what we also know is that it is often a low-level medical concern that doesn't get dealt with and goes on for a decade before they finally get to a spot where they're ready to do something about it. But now they've got a chronic disease, they've got other things going on that shorten their lifespan. And so we want to try and address that by welcoming them into primary care as quickly as possible. We have our vocational support. We have 2 full-time vocational coordinators helping people with resume building, getting jobs, getting back into the community, connecting with DES for rehab services, administration services and support, and all of that. Next, we have an ACT team, or assertive community treatment team. It is for adults with serious mental illness that typically in the past have struggled to participate with ongoing services on their own. And so we offer case managers, nurses, vocational coordinators, peer supports that are making multiple weekly contacts with folks so that we can make sure that they're taking their medications to maintain stabilization as much as possible, as well as just kind of keeping eyes on them, making sure that they're staying safe, that they're eating their meals, that they're taking care of their house, that they're taking care of themselves, that they're not having problems in relationships or having communication difficulties. And then we teach a lot of daily life skills, and we have some good groups going for our ACT teams. Other specialty programs, some of this is a little bit new for us. We just launched a mobile unit. It went out for the first time yesterday. So when I say it's new, it's very new. But we have a lovely 29-foot truck that's about to get its decals put on it soon, where we can respond to community or disaster events for crisis response, crisis support, or we will be taking it to Williams one day. We will be taking it to Ashford. We will be going out near, as close to the reservation as we can get sometimes. And so we do have the availability, as long as we can schedule appointments for it, where we're going to be able to provide that. One of the main things we're focused on is keeping people compliant with their injectable medications, because it's a really tough set of cats to herd, I guess. And so having a mobile unit where they could actually just walk up to a truck, climb on, get their shot, and go back in their house is going to be a lot more effective than just trying to get them to come to the clinic sometimes. We also have a moms and babies program, so that a year, or the start of pregnancy all the way through a year after giving birth, there are services available for intensive care management, a lot of coordination with medical providers, ongoing therapy, community resources, and both prenatal and postnatal care. Postpartum depression is only going up statistically as far as how often it's happened, how prevalent it is, and how severe it is when it's happening. And so we offer that service for a lot of folks. It's a very specialized, dedicated team that works with that population. There's some even fun, cool, random stuff about it where you can customize your own lullaby and have it performed by one of the symphony orchestras around here. And they'll record it for you and send that with you so that you have something to provide to your kid. And it's a really amazing.
It's a fairly new program, and just yesterday, their group, they actually had about 9 or 10 women show up with their babies. So we were having 1 or 2 come in, and yesterday I walked in and it was a full house. So pretty exciting, and those numbers are coming in on a regular. So it's pretty exciting.
We offer first episode psychosis or early intervention for psychosis. For folks that are 16 to 35 that are experiencing their first symptoms, we want to try and catch it early and do early interventions so that they're not going 10 years down the road without treatment, developing potentially lifelong psychotic symptoms, prevent suicide, and reduce risks for loss of relationships as well as just functioning. And so with that, we are also relaunching domestic violence offender programs. They're gender specific, but we're focused on safety and rebuilding skills, communication. And then that program is also referring to individual therapists as well, so that or family therapists, so we can do follow-up to engage them in different ways as well.
Do you know which curriculum you're using?
But we can go and get an answer. I'll have to look it up and let you know. Yeah,
Trevor, when has that launched yet, that program?
it's ready.
It's ready.
It's ready.
Okay.
So we're taking referrals for it right now.
Okay.
Is it virtual or in person? So we can use our remote clients coming in.
Mhm.
Okay.
Yeah.
So I know Susan and I are going to meet, so she can tell me how that process is going to work. So then if it's just us putting them on that provider schedule so that they can do that initial interview.
Awesome.
And then groups, just some examples of different types of groups that we offer, but other providers offer a lot of these things as well. Seeking safety is a big one that gains a lot of traction with folks, particularly if they have experienced trauma and they're having addiction issues. But we even have things like yoga, meditation, mindfulness, art therapy. For some reason, our music group never got off the ground. It's probably because everybody facilitating was terrible at playing instruments. But we often try and kind of brainstorm and restart different things at different times. I know most folks are focused on the adults, but we also have birth to 5 services for development and progress assessments, providing family support and skills training, and coordinating with pediatricians. We have a partnership with Mountain View Peds to be able to offer care management support to anybody coming in their office with access to one of the commercial insurances we're able to accept. For 6 to 21, next slide, please. We do a lot of in-school services, more and more all the time, where we're able to connect with folks and provide those services in the school. A lot of the schools are very open to setting up space for us to provide services. So that's been very exciting for us. And we have a lot of psychological evaluation and testing. We also have applied behavior analysis treatment, so we can do functional behavioral assessments for folks with potential intellectual or developmental disabilities, or just folks who therapy isn't working, but there's some sort of block in their system of processing and functioning that we need to work through and maybe work with families to figure out. And then a couple of just lists of resources and links. The different behavioral health homes serving Coconino County, TGC Southwest Child and Family Support Services, and Encompass up in Page. Those are the different health homes that can provide a variety of different services. Everybody's got telehealth services available. Everybody's serving adults and kids. I mean, CFSS usually they stop around 21 most of the time, but they can go on for certain other things. And Encompass up in Page has always been a really amazing partner and provider for folks in that area. Some other specialty providers, we definitely can't recommend enough peer support services for folks. It is amazingly powerful to every single person going through services when they can talk to someone with lived experience in having bipolar symptoms, lived experience in using substances. And so there are a lot of providers and more all the time are coming, stand together and recover. I don't even know if they're open yet, but they showed up about 2 or 3 months ago. And they've been in Phoenix forever and ever and ever. It's just really exciting. If you've worked with Hope Lives before, they're just incredible. They're so dedicated. And there is what I really appreciate about the change in regional behavioral health authority over the last couple of years, forgive me, health choice, is that the payment models have shifted. So we are free, all the health homes are free to refer to anybody to get any service. You can get some services at Southwest and some at TGC. You can get some at Encompass and some somewhere else. And so we can blend all of this together with all the various resources. If any of you have worked with or heard of services at NACA before, they do tremendously specialized but amazing work with people that are indigenous, and they serve not just indigenous folks, but they can serve everyone as well. And so those services are available. NAH or Flagstaff Medical Center have their inpatient units for 12 and up adolescent services as well as adults. And Terrace, everybody knows because they're all over the place doing all the things with all the people. So I think that's the last.
That is the last slide.
We have a whole minute for questions.
Cool. I appreciate you guys. So I did open it up to the chat. I mean, if anyone on the chat has any questions, throw them in now, or obviously if you guys in here have any questions, please feel free to ask them. I haven't had anything come up in the chat though, in terms of questions. Okay, so I have a question here from one of our county attorneys. He says, I'm a prosecutor and often require substance abuse screening and plea agreements. Is that the best way to get someone who may be low risk to have contact with treatment, or are there alternative options? Just the substance abuse screening.
Yeah, typically we can just do a substance use assessment and leave it at that if the person's not interested in engaging in other services, and any of the behavioral health ones can do that as well. If it's just a screening, what'll happen is they'll see an intake clinician that's a master's level clinician. They'll go through the process, and then the ending just kind of goes whichever way it needs to, as far as if you have a substance use issue and you're wanting to pursue treatment, then we'll get you set up with a treatment plan for that, and talk back to the referral source, let them know, yes, they are engaging, they're going to do this, etc. If they come in and they have a screening and they don't meet criteria for diagnosing a substance use issue, at that point, then we would refer that back as well with that information. And we've gotten a lot better at closing the loop as far as communicating back to referral sources. I know in the past that there's been some struggle with that with all the providers, but we're tracking that on everybody coming now, just making sure that we're closing the loop, sure we're getting back to the people that are referring to.
Yeah, and I think it's pretty common for like the justice partners. You know, we see a lot of, whether it's in plea agreements, asking for substance abuse screenings, or just on terms of probation. It's very common to see requests for substance abuse assessments.
Sure.
So are you guys able to do that independently of actually enrolling somebody?
Yes. We can just do an ASAM.
Just do an ASAM.
We regularly just do an ASAM in the jail. That happens usually like 2 to 3 times a week from the one staff member, and I let others as well.
So if you could, even with your, if you could include like a lateral information that says it's just for the plea agreement, or if you have any history that they've had clean UAs for the last, 12 months that they've been on probation. That's helpful because we're going to pass that on to the master's level clinicians so that they can document that in their assessment.
And I think the struggle we run into is that I know this is going to be shocking to all of you, but some people minimize their symptoms and their use. And so
No way.
I know it's brand new information, but it's definitely something that happens more often than not. And so anything any information about use, any information about what got them in trouble, anything like that is super helpful, especially if we're just focusing on a screening.
Awesome, thank you. All right, any of you guys got any questions?
How long do you guys maintain your records? So a person did a screening and needs it years later because the case becomes they prosecute it years later. How long do you maintain records so that person can get their records?
7 years.
Awesome.
That's how long it takes to.
1995 records are.
Okay.
We had that question last week.
Yeah, that just came up recently.
Nice. Awesome. So for anybody that might not have caught it in the beginning, so I will be sending out to everybody who participated, I will be sending out this slide deck that has this information in it with obviously at the end with the links to the other agencies. And we do have some handouts, including that minimized intake packet that we will be sending out as soon as possible to everybody who participated.
And then the medical screening for detox.
Yes, and the medical screening form for detox, which is always helpful. So, yeah, but I mean, if anybody wants to throw their questions in the chat, do it now. We don't have any other questions in the room, but I want to just take a minute to thank you guys for being here. This was our first of these sessions of webinars, so I think it went relatively well. We appreciate y'all being here, and we will provide you guys contact information when we send this all out as well. So if anybody has further questions that they want to ask, you know who to contact. So I don't see anything popping up in the chat. So I appreciate everybody being here today. And yeah, have a good afternoon.
So,
Thank you.
Yeah, thank you.